Welcome to the Peds NP, Pearls of Pediatric Evidence-Based Practice. Thanks for joining us again for our third case study in the series that breaks down the ABIM Foundation's Choosing Wisely campaign, an evidence-based endeavor meant to spark conversations between providers and patients about what tests and treatments are really necessary. I'm your host, as always, Dr. Becky Carson, pediatric nurse practitioner and clinical faculty member at the Duke University School of Nursing. This series highlights that more is not always better. And since you're listening to the Peds NP, you know that I love to take it back to the patho, to understand the underlying mechanisms that guide our decision-making. This connection will help you consider how we're being good stewards of our healthcare resources. The background on the Choosing Wisely campaign and its mission is described in episode 79. So rewind to listen to the underpinnings of how it became a resource utilization stewardship movement. And once you're ready, these case studies will help you apply important concepts from your core pediatric knowledge to those tricky situations that can be so tempting to add on the extra diagnostic tests and treatments. There's something vexing and perplexing about these presentations, perhaps rooted in our habits and probably our experience. Anxiety that something could go wrong. So we want to do something more for the child. But instead of pacifying ourselves, our colleagues, or the family by layering on extra tests and treatments that can actually be harmful to the child, this campaign and this series is about taking a beat. Take a beat and then apply your foundational knowledge to the problem to come up with an evidence-based solution that has everyone on the same page. This series is complete with peer review from my acute care P&P colleagues using a standardized approach to quality assurance. You can learn more about the peer review process at thepedsnp.com/peer review. Before we get started on today's case, I want to remind you of our learning objectives for the case-based discussions in this series. Today's case will follow a child with a fever and cough through the emergency department to inpatient admission and hospital discharge. We'll think about microbiology and settle those suspicious feelings that make so many providers escalate care beyond what the evidence suggests, using concepts from the Choosing Wisely campaign to help guide your management and remain a good steward of resources. And because the family is part of the patient-centered care in pediatrics, we'll note points that provide reassurance to concerned caregivers or the multidisciplinary team. Let's get started with our next case, a child with fever and cough. Remember, this vignette is not intended to be a black and white picture. I'm going to leave lots of shades of gray, some features that are vague, and maybe some blind spots will remain. This case is about taking the journey, being thoughtful, and thinking about how you think. Let's start off by pretending that you're the PNP in the emergency department and the next patient to be seen is a previously healthy, immunized, school-aged child who presents with fever for 8 days and cough. Let's pause real quick. Why did I highlight that the child is immunized? Because clearly it's an essential piece of information that shapes our thinking from the jump. It's a marker for infection risk, and we can use our knowledge of epidemiology to consider which pathogens are most common in the child's age group as it meets the clinical concern to further shape our management. If you work in acute care, it can be really tempting to feel like you don't need to memorize the immunization schedule because that's a primary care thing, right? Wrong. In this new age of vaccine hesitancy and refusal, you'll encounter an increasing number of children who are unimmunized or partially immunized. So you'll need that information to shape your differential. But I can guarantee you that the caregivers won't list out every single missing vaccine. They'll just tell you that they're not up to date, or they'll tell you that they don't accept vaccines. It will be up to you not to take their immunity for granted, mentally cross-reference the list of vaccines not received, and reinsert the unprotected disease processes higher on your differential. All right, that's enough of that soapbox for now. Let's get back to our case. The medical record shows that viral testing at the PCP early in the illness was negative, so no flu, COVID, or RSV. From the door, your rapid pediatric assessment triangle to determine sick or not sick has your spidey senses tingling. That child looks toxic. So you take a step further inside with a plan to move quickly on this child. Vitals, 40 degrees Celsius. That's super febrile. Heart rate, 144. That's super tachycardic. Is it from the fever, dehydration, pain, or something else? Blood pressure of 90/40. Oof, that is soft for a school-aged child. A respiratory rate of 48. Yikes. Okay, tachypneic. Is that from the fever, a respiratory concern, or acidosis? Your SpO2 is 82%. Okay, we are hypoxic. We are moving more quickly. Thankfully, the multidisciplinary team has the same intuition you did. While the team of nurses and emergency techs moves quickly to implement PALS algorithms for this child who could rapidly deteriorate at any minute, you dance around their interventions to do what you do best: assess. With a cardiac monitor in place and 100% oxygen via non-rebreather, the pulse ox improves to 92%, and you begin to obtain a history at the same time that you complete the physical exam. But since that's pretty hard to follow in a podcast, I'm going to break them up. The caregiver offers a pretty simple history. The illness started as a cold about 8 days ago when everyone in school seemed to be under the weather. Runny nose, cough, congestion. There was fever on the first day, so that was when they saw their PCP who did all the viral testing. All of it resulted negative. They continued supportive care with Tylenol and ibuprofen, and the fever stopped somewhere around the second or third day. The days crept by with mild lingering cold symptoms, only to return with a vengeance yesterday. Since then, the child has had increasing difficulty breathing, and they've been gagging on the sputum, thankfully never really having true post-tussive emesis. Antipyretics were working for a while, and the child was still drinking some with a normal urine output, but now it seems that the fever never really goes away and spikes immediately after the medication wears off. To top it all off, there were some questionable periods of cyanosis during those coughing spells and an increasing lethargy that brought the family to seek emergency care. You take a moment to praise the caregivers on their supportive care and their choice to seek help today. Things weren't going in the expected direction, so it's time to look at it with new eyes. On exam, the child appears altered, waking up to the sound of your voice, but immediately going back to sleep. Auscultation reveals focal right lower lobe crackles and scattered wheezing throughout. There's an increased work of breathing with substernal, subcostal, and intercostal retractions. Given hypoxia and the degree of distress, a chest x-ray was ordered and confirmed a right lower lobe pneumonia without evidence of suppurative pulmonary complications that would need further treatment, such as a parapneumonic effusion, a lung abscess, or empyema. You know this child needs to be admitted, but the ED management isn't quite complete yet. Did your differential end with pneumonia? What do you do next? Well, we all know that ED nurses are awesome and work well with standing algorithmic orders. So they've already got you covered with that easy, low-hanging fruit. They gave an antipyretic, nebulized albuterol, and they have the fluid bolus ready. Remember, with that low blood pressure, the tachycardia, and altered mental status, fluid resuscitation should be your first priority. Why? Well, I hope that it's because sepsis was on your differential bingo card today. I know my listeners, so of course it was. So how else would you like to evaluate for it? Think about how sick this child appears. Are they well enough that you're going to order some basic labs, then wait 30 minutes for the lab to process the samples, and then let those results guide your management? Like you're watching for leukocytosis and then you'll give antibiotics if the white blood cells are over 20,000? Or were they so sick that you're going to rush into the room with syringe in hand and give empiric antibiotics before any labs are drawn? Those are good questions, but you know how I'm going to answer before I even mention the choosing wisely recommendations. Look at your patient, the objective information, and take it back to the patho. Remember those vital signs we highlighted in the physical exam that showed a very sick child? The sepsis red flags should be waving high in the sky right about now. The Society of Critical Care Medicine released international consensus criteria in 2024 for identifying and managing pediatric sepsis and septic shock. These guidelines emphasize the identification of organ dysfunction using the Phoenix Sepsis Score to diagnose sepsis and septic shock. It's infection-associated organ dysfunction, not necessarily infection-associated systemic inflammatory response syndrome, like we previously called it. We won't go into this now, but I do want to highlight these guidelines and invite you to read them and even try applying them to this case. With all those considerations in mind, the Choosing Wisely campaign would advise us to obtain the appropriate blood, urine, or other appropriate cultures prior to the initiation of empiric antibiotic therapy, excluding exceptional cases. And since organ support with fluid resuscitation is the priority, and the antibiotics won't have an instant alteration in your clinical exam, encourage your IV team to get the blood culture before giving empiric antibiotics. Certainly, the CBC will be informative and can even identify significant complications like disseminated intravascular coagulation, or DIC. But the blood culture is going to give you that definitive identification needed to expertly manage this. Take note that sputum cultures are difficult to obtain in children and have a low diagnostic yield. All right, luckily, the child's blood pressure and mental status responded well to the fluids and antipyretics. The vital signs have improved and are all normal. Phew, nice work, ED team. The appropriate labs have all been sent and you're ready to treat this pneumonia. But what antibiotic or antibiotics should you choose? What feels tricky about this case is the fact that pneumonia is the leading cause of death in children under age 5 worldwide. It can be so tempting to throw a broad-spectrum antibiotic like ceftriaxone at the fever and feel confident that you've blasted out whatever was causing this infection. But that's not necessarily the case. Antibiotic resistance has risen due to the uncontrolled spread of antibiotic-resistant pathogens in hospitals and communities, poor antibiotic stewardship, and poor adherence to clinical practice guidelines. Streptococcus pneumoniae remains the most common bacterial organism in community-acquired pneumonia. So a beta-lactam antibiotic like ampicillin is the best choice for uncomplicated community-acquired pneumonia in otherwise healthy, immunized, hospitalized children because it concentrates well in the lungs. What's so bad about broad-spectrum antibiotics? Besides their increasing resistance to certain strains of strep pneumo, broad-spectrum antibiotics like ceftriaxone have anti-anaerobic activity, so they also contribute to C. difficile infections. And since we're not talking about critical illness or a failure to improve with empiric antibiotics in this case, I'll save discussion of adding a macrolide like azithromycin to treat atypical pneumonia for another day. For now, it's appropriate to use our trusty old ampicillin to treat this community-acquired pneumonia. The child improves after several days of antibiotic therapy and is ready for discharge. But what should the discharge plan be for antibiotics? Believe it or not, there are plenty of cases where a child had a peripherally inserted central catheter, or PICC line, placed for prolonged IV antibiotics. And that's a terrible idea in a child who is clinically improving and able to be transitioned to an appropriate oral agent. I usually saw these kids when they would show up a few days after discharge because they broke the catheter hub, pulled out the line, or allowed bath water to saturate the sterile dressing. Up to 40% of children with PICCs will return to the emergency department with a PICC complication, a broken line, a line infection, or accidental removal. So, especially since extended intravenous therapy via a PICC line does not improve overall cure rates for common infections over their oral antibiotic equivalents, and the PICC line's mere presence subjects the child to a risk of complications, it's time to transition to oral amoxicillin for the remainder of a 10 to 14-day course. But wait, should we do a full 7 days of IV antibiotics? Not necessarily. The Choosing Wisely AAP hospital medicine recommendations tell us not to prescribe IV antibiotics for predetermined durations for patients who are hospitalized with infections such as pyelonephritis, osteomyelitis, and complicated pneumonia. Instead, consider early transition to oral antibiotics. And as we're talking with families about the child's condition at discharge, let's offer one more plug for immunizations, especially the annual influenza vaccine. I hope that throughout this case, you've noticed the need to clinically assess the patient to make these decisions. And I hope that you're thinking about how your assessment of this hospitalized child with pneumonia will include information gathering from a number of sources, including labs, bedside nurses, and caregivers. That's a key to making the Choosing Wisely lists work. You've got to be comfortable in your assessment skills so that you're confident in your diagnosis. When all of the stars line up into a clear constellation of symptoms, then use the Choosing Wisely lists to help avoid the unnecessary tests and treatments that won't impact patient outcomes. While some of these lists are growing old and need to be updated with new trends in microbiology and current data to guide our evidence-based recommendations, the overarching concepts surrounding resource stewardship remain steadfast. I hope that you'll join us again next time when we talk about one of the most common pediatric presentations in gastroenterology. We'll manage the case with thoughtful, Choosing Wisely-based decisions that help us become better stewards of our resources while avoiding potentially harmful testing and treatments. Don't forget to like and follow the Peds NP, where we discuss the practical application of evidence-based practice in a conversational way that helps you synthesize and transform the best practices from the literature into your clinical bedside skills. Thanks to the acute care P&P faculty who reviewed this episode. The Peds NP is built on grassroots foundations in communities of interests. So share it with a colleague, pass it along to your classmates, and text it to a friend. There's no relevant disclosures for this episode of the Peds NP. Follow me on Instagram at the Peds NP podcast. Email me at thepedsnp@gmail.com. And remember, those tricky situations don't have to paralyze you. Use the evidence to guide your practice. I'm Becky Carson. Take care.